joining everybody. And it's really meant to just be a learning opportunity. It's been obviously a strange and tough year academically for you guys. So job well done taking this step to being, you know, um, taking your education seriously and joining us here today. So it's kind of new for us to kind of learn this. So we'll just kind of work through it together. What we'll do essentially is a case. Um, we'll just ask questions. We're not going to give answers throughout. We'll just see what you can give us. And at the end, we'll allow some time for feedback as well as questions from anyone who's joining us over Zoom. So, Caitlin, we'll go ahead and start with you. Let's just, are you okay just giving us a quick introduction? Let us know who you are, a little bit about yourself.
Sure. So my name is Caitlin Minahan. I am a fourth year student at Kent State University. I am originally from the Hudson Valley, New York. I am the oldest of three siblings. I love to run. I was a cross-country collegiate athlete in college. I really try to live by a healthy balance of working out and studying and taking my school seriously and academics. That's just a little bit about me.
Cool. Well, thanks for joining us. What are you looking for in a residency program?
I'm looking for a team approach. I really like to work together with my residents. I would like a good environment to work off of. I would like a program that pushes me and takes me out of my comfort zone and gives me the best surgical training that I can have, and just a good overall environment where I'm not scared or nervous to ask questions. Just a good positive environment for me.
All right. Very good. So we'll get started with the case for you.
Sure.
All right. So here we've got some emergency room call situation. You've got left foot and ankle pain in a 56-year-old female who fell from a height. She was just doing some general house maintenance, about 15 feet fall. She's unable to walk on the left side, did hit the left arm as well. Past medical history you can see here: obesity, breast cancer, anxiety, hypertension. Here are her medications, and she just has seasonal allergies, nothing significant there. Rare use of alcohol and a non-smoker. So, what are some of your initial questions, and what would you like for this patient in your workup?
So first I'd like to go through the primary survey. So is the airway, how's her airway, how's her breathing, how's her circulation, any deficits, neurologic deficits, if the if it's fractured, if there's anything open to the foot or ankle, and vitals.
Good. All right. So, objectively, we're taking a look at the patient to start. She's stable, BMI 32. She is alert and orientated, so no real distress, but certainly in some pain. She has some abrasions both to the upper and lower extremity on the left side, palpable pulses, pretty significant edema, does have sensation intact as well, and some guarded range of motion to the left with tenderness on your examination. No really obvious gross deformity as she's pretty edematous. So before we move on to some more lower extremity stuff, let's do a bit of a medicine review here. Got some questions. So what risk factors did you pick up on this patient, assuming she could be surgical, right, that may indeed increase her risk of DVT?
Her obesity, her BMI being 32.
Good. What are some anticoagulants you're familiar with?
So you can do heparin, warfarin.
Good. And then so you picked up she's on this medication, tamoxifen. Are you familiar with that? And you know what is the use or mechanism of this drug?
No, no,
No. How about vitamin D, what's normal level for that?
Normal vitamin D level, I'm pretty sure 20 milligrams.
Okay. So we've got our background here. What's next for this patient would you like to see?
Some x-rays. I'd like to have left foot and ankle x-rays.
Perfect. So here's her presentation. You can give a quick read on these.
Sure. So this is a AP view of the left foot. On the left, I'm looking at increased soft tissue density of the medial malleolus. There seems to be no skin tenting noted to the ankle joint.
Okay. Any findings here otherwise, or more images? What do you need?
Yeah. So can I have a lateral view and ankle view?
Sure. So here's our ankle here.
Okay.
Now we can see.
So looking at an AP and mortise view of the ankle, I see the medial clear space is within normal limits. What? I'm sorry. The tib fib overlap is within normal limits. There's there is skin tenting on the lateral malleolus of the left ankle.
Okay. Anything else?
No other significant findings.
There we go. How about that one?
So this is a non-weight bearing image of a non-weight bearing lateral image of the left foot and ankle. There is a fracture noted to the talus. I would say there's a dislocation of the navicular on the talus. There's a fracture of, so a fracture of the navicular. I would say there's dislocation of the navicular onto the talus.
Perfect. Yeah, that is your one liner for your attending who you're calling on the phone to let them know what you took on call here. What are you telling them?
So this is a talonavicular dislocation fracture of the talus. That's a fracture of the talus.
Okay. So she hit her left upper extremity as well. Can you do a quick read on this too?
Sure. So this is a lateral view of the left arm. I see no significant fractures noted to the arm. There is increase in soft tissue edema noted around the elbow. No other significant.
Good.
Okay.
So with what you've seen here,
Mm-hmm.
what's your assessment and what's your plan for this patient?
Okay, so this is a navicular fracture, a displaced navicular fracture. So what I would want to do is I would want to immobilize. I'd want to put them in a Jones compression. I would want to do an OREF of the talonavicular joint, bring them into surgery, and have them non-weight bearing for 4 to 6 weeks. And then,
Okay. Are you doing surgery today, tomorrow, 2 weeks from now?
so since neurovascular wasn't intact and there was no occlusion to dorsalis pedis, I don't think we would need to do it immediately. We could do it within the next 2 days. It wouldn't be an emergent case that we would need to bring in right away. But I'd want to do it as soon as possible. So maybe within a day or so. Do ORIF of the talus of the talonavicular joint.
All right, so this is immediate post-op. This patient was brought to surgery. Explain your findings here. What was done?
So what they did is they just put a fully threaded screw to hold the navicular fracture into place.
Do you know the AO steps that place in this particular screw?
So you would do, first screw the near cortex, the far cortex, then you would over drill, under drill, and measure, tap, and screw.
Okay.
Countersink, measure, tap, screw. What is it?
Questions regarding this particular case. What's the blood supply to the navicular, the main blood supply?
I would say dorsalis pedis artery.
Okay. What do you think was the mechanism which caused the fracture to present as it did?
A dorsiflexion. I think it was a high energy fracture of dorsiflexion, eversion fracture.
Okay. If you were to have attempted a closed reduction, how would you do it?
So first I would increase the deformity, then I would distract it, then I would reduce the deformity and splint it.
Okay. Any other concerns when you have a fall from a height? What particular fracture could occur with it?
Lumbar fracture, so I'd want to get lumbar x-rays.
Okay. Good. Nicely done, Caitlin.
Thank you.
So yeah, feel free, Doctors Chu, Dr. Cobb, Dr. Haas, to give any feedback here. I think we can kind of briefly just walk through it if you guys want. I think Caitlin, you did a nice job just with your workup. The goal of these interviews, in my mind, always is not to get the questions right for the students who we were interviewing. Rather, it is for them to convey to us that they would be able and capable of taking call as a first-year resident. So residency is where you learn how to do surgery. It's just that background knowledge and the ability to work something up, I think, that you should develop as a student. So it just having an appropriate workup is all you need to do. These fine details of how surgery has to be done, that's what you're going to pick up in residency, right? So that's all we want to see with these, is that you're able to walk down this and eventually come to a reasonable answer. So I like to do medicine review. This might not be everywhere that you all end up interviewing. This is something our program does. The reason we do it is maybe it's twofold, to kind of throw you off and just kind of get a more general idea of your knowledge of medicine in general. But we're also a primary admitting facility where I did my residency, which a lot of places are. So usually the foot is not going to kill the patient, but whatever comorbidities they have definitely can. So just having a good background of medicine, or at least a curiosity for medicine and what comorbidities patients may have, is really important. So that's why you'll see it here. These are podiatry interviews, so you have a few weeks until your crit process starts. I'm not saying to pull out your USMLE textbooks and cram for that, but just have a working knowledge of big things, maybe.
Yeah, Caitlin, I think Paul's exactly right. If the fine details at the end, that'll come later. But I think your workup was good. Don't get hung up on an X-ray, right? The first
Yeah.
AP and MO, there wasn't anything there, right? And so
Yeah.
you went to the ankle and there wasn't anything there, and move on to the lateral, right?
Okay.
You can see some of these programs will put the best finding at the end. And so do a cursory. If you get through all of them, it's okay. Say, hey, can I see that MO again? Can I see that AP? Maybe I missed something, right?
Okay.
And then initially, when we're doing surgical stuff, that initial breast cancer diagnosis, that's the main fear for us, right? So when you
Yeah.
go back in that initial read, when you see cancer, that should be a huge red flag. Like, okay, this is something I'm gonna have to pay attention all the way through the recovery phase. Okay.
Okay. Yes.
But I thought you did a good workup.
Thank you, Dr. Cobb. Thank you.
Definitely. And then obviously this is to throw you off too. I don't know how many people do it, but this is just to get you thinking. X-ray is an X-ray. If you see a fracture, you can describe a fracture. It doesn't matter where it is. You don't even have to remember the name of the bones, to be honest with you. If you see a fracture, you can describe it. If you see dislocation, subluxation, whatever it is, I think you can reasonably describe it. So just stick to your principles. Even if I ask you to fix a radial fracture, AO principles, different plating techniques. And then nice job on coming up with your surgical plan. So one thing we didn't mention here was there was an attempt at closed reduction that just happened to fail, which can certainly be the case in these. And then the patient was brought to OR for fixation.
So yeah, Caitlin, be careful with regards to your terminology and your nomenclature of the fracture and the dislocation and subluxation, and of which joints, as you talked about, having a dislocation of the talonavicular joint. I think anytime that you talk about a dislocation of a joint, some of that immediate treatment should be an attempt at closed reduction.
Okay. Okay. Thank you.
Cool. And then at the end here, this is just simple. These are podiatry things. So you pretty well knock these questions out. So that's a textbook answer for closed reduction. Indeed, if you did exaggerate this, then now you might have an open fracture. So in reality, you'll learn through residency how a closed reduction will ultimately be done. So this particular one might take a different maneuver than an ankle, which takes a different maneuver from an MPJ. But yeah, you did a nice job on answering these questions for sure.
Thank you. Thank you for your
comments from the docs.
Yeah, no, I like Dr. Haas's comment, Caitlin. Just be really particular with your nomenclature, with TN dislocation versus just a navicular fracture.
Yeah. Yeah.
Just be cautious.
Okay.
we want to overread because we get nervous, right? And so just describe what you see. You don't have to overread it.
Okay. Okay. Thank
Yeah,
you.
I think the other docs touched upon it. I'm just kind of reiterating. We put up X-rays just for completeness sake sometimes, and it's not like a test where every single question has something out to trick you. That ankle was totally normal, so it's also helpful for you to verbalize as you're reading the X-rays what you're looking at. You can say that I'm right now eyeballing the median malleolus. It looks, I don't see any radiolucent lines there. It looks overall intact to me. Now I'm looking at the the tibio-talar joint or the fibula, and it looks pretty good to me. And so be careful not to overcall it because the fibula wasn't really tenting exactly. I think you were kind of reading into it and said that it was tenting just to say something. So yeah, just be careful not to get hung up on that.
Sure. Okay. Thank you. Thank you for pointing that out.
Oh, and one other thing I think was really important, Caitlin, that you did well. The residencies, although maybe if you rotate at a place, they'll know you, there's always going to be someone there who might not. So they'll ask you to give a quick description of yourself. You did a really nice job of letting us know who you were, which was fantastic. You told us where you're from. I like to ask that question, where you're from. And when people say, you told us your actual hometown, but when you say, oh, I'm from Kent State, I just think, oh, you're born at Kent State University. Like, so let them know who you are as a person. They know you're a podiatry student. So give them a little bit about yourself, which was, I thought was really cool that you did.
Thank you. Thank you very much.
I'm gonna expand it for that.
Any questions from anybody who's observing right now? Feel free to unmute yourself and ask a question or type it.
All right, David, you want to go next?
Sure.
All right, maybe the volume numbers because mine.
Can you guys hear me?
Yep.
Okay.
One doesn't seem to well. So
Maybe the mute button or something on yours. I know it's a pain. All right, a little something different for you, David, okay?
All right.
So what we're going to do here, we're going to do a little bit of rapid fire. We've got basic questions and we're going to just look for your answers. Before we get going though, let's hear a little bit about you and a quick introduction.
Yeah. So my name is David Chandra. I'm a fourth-year student at Kent State, Kent State College of Podiatric Medicine out in Independence, Ohio. So a little bit about myself. I'm actually born in India. We lived there with my family for 6 years, moved out to Ohio in 2000. And then we've been living in Michigan for the past 20 some years. But I had the fortunate opportunity to go back to Ohio and kind of wrap up my academic career there. I started my first grade there. Now I'm finishing up my podiatry schooling out there as well too. So that's a little bit about my background. I have a younger sister. I love hanging out with family, being with friends. I love sports, and basketball was something that I enjoyed back in middle school and high school as well too. So that's a little bit about myself and who I am.
Great. Well, we seriously appreciate you joining us today. So thanks so much for taking this opportunity for your education.
Yeah, thank you for having me.
All right. So what is the function here of the medial plate?
The medial plate is, the function of the medial plate here is to compress the fracture down that we can notice on the left image of the medial mal.
Okay, what do you know the anatomical AO function here?
Yeah, so the anatomical AO function, so to provide rigid internal fixation, to provide the proper alignment for the fracture that's noted in this image. Would you like all the 4 principles, or is it just the?
No, that's fine. That's fine.
Okay.
What's the most likely affected nerve in this patient?
The long thoracic nerve.
Good. Can you describe the hardware here and maybe give us an idea of what you think procedure could have been?
So you have a fusion of the midfoot, your entire TMTJ joint, your entire Lisfrank's complex. So probably some form of an open reduction internal fixation of that joint, possibly due to some injury to the Lisfrank's complex that might have been present. And there's 2 crossing screws that are present from the base of the first metatarsal into the medial cuneiform, and then you have 2 screws that are going from distal lateral to proximal medial from the 3rd and 4th metatarsal bases into the navicular, and then you have 2 screws that are directed proximal lateral to distal medial from the cuboid into the bases of the 2nd and 3rd met. Identify surgery.
Let's see if our screen will catch up.
There we go.
There you go. Little lag there, David.
Oh, no worries.
There's some surgical options for this patient.
Probably some form of fusion at your acetabular joint on the right hip joint, and to probably fuse up that joint just because of the arthritic changes that are noted in that area and the decrease in joint space as well. So I would believe that that's a surgical option that you can do there. In addition to that, I'm not completely sure. I can definitely look that up and get back to you on that as well.
Okay. Describe the procedure and fixation in this case.
So you're doing a subtalar joint fusion here, and you have 2 6-0 cancellous screws that are being placed from the from your calcaneus into your talus, so to fuse your subtalar joint. Partially threaded cancellous screws.
What may be some reasons to perform this procedure?
If the patient has any pain in the subtalar joint range of motion, or any arthritic changes in the subtalar joint, any other arthritic changes primarily would be the reason for fusing the subtalar joint, and pain would be the 2 reasons, what I would say. Or if there was any form of fracture or dislocation that was within that joint as well too.
Let's say this patient has pain and is looking for a revisional surgery. What are some options you may give them?
So since you do already have a hemi implant put in there, you can possibly do a fusion for the patient to just limit the range of, just to remove the range of motion if that's causing them any form of pain. So you can do a fusion. Would you like any form, like specific types of fusions, or is it just in general that you want?
Just
like,
general surgical options. So anything besides a fusion you could give them?
I would say the best probably for this patient would be a fusion, since you've already used an implant. So that's what would be my best answer for this patient.
Okay. You remember the stain and counter stain in a gram?
This is taking me back all the way to histology in first year, but I'm not sure if I know it confidently enough, but
that is all right.
yeah.
Could you name any procedures that could spare this patient's joint if they wanted a revisional surgery?
Joint strain procedure. Let's see. Could you do you could possibly do a TAR? I mean, I know if you can't fuse a joint, that would obviously disrupt the joint space and everything like that, but
Okay, good. you know what implant is used in this case?
So the implant, is that the in-bone implant, one of the implants that you use for the ankle joint? I could be wrong. I mean, I'm not sure of my implants exactly. Can definitely review that, but
No problem. Can you give us a classification scheme for this injury and even possibly classify it for us?
so because of the fact that it's an open fracture, an open wound, I would use the Costello-Anderson classification, and I would say that this is a Costello-Anderson grade 3. I want to say 3B. Actually, sorry, 3C, because there's also contamination from soil injury too.
Good. Do you know the steps in reducing this deformity?
So you have first you want to address your cavus, and then you want to address your forefoot adductus, and then your varus deformity, and then finally your equinus that's present, and you want to do that last.
Great. Can you give a quick read of this image?
Okay, 1 second. So on the sagittal view, you notice I'm trying to find the right word for that. A tumor in a bone possibly located in the anterior ankle joint area, just superior, just anterior to the ankle joint. In the middle you have your T2 weighted image, and then your T1 and then T2 on your right. I would want to say some form of lipoma noted in that region, intraosseous lipoma.
So if this patient's having pain, what are some potential interventions you could do here?
So you, on the left side,
foot and rear foot.
Okay. So on the left side, you have your weight-bearing view of a skeletally mature patient, weight-bearing view of the lateral view of the left foot. You notice major arthritic changes to the midfoot as well as your rear foot as well in your subtalar joint. And on the right, you have your an AP view of the left foot, and you can also notice the midfoot arthritic changes that's present in that image. So I would probably, for the rear foot, because of the extensive nature of the arthritic changes, possibly do a TTC. I mean, that might be a pretty aggressive form of treatment, but just looking at the changes that you can notice in the rear foot, and this, especially at the subtalar and ankle joint, that's probably what I would go for the rear foot, and probably some form of fusion as well for the midfoot to reduce any form of issues or problems that are noted in the midfoot as well too for this patient. But I mean, I don't notice any form of that would be what I would do for this patient.
That's good. Any guess as to what maybe congenital or acquired deformity could cause this?
From the image, it may possibly CMT.
Good. Here's a. Just keep freezing here. All right, let's do a quick medicine review while we're here too. So do you remember or recall what does a high TSH mean when there's low free T4?
let me think. So for that, would that be hyperthyroidism?
Okay. So you have a patient who's bacteremic, does have a history of rheumatic heart disease. Do you know a special examination you'd be interested in performing for that patient?
Possibly a chest X-ray.
Okay. Do you know a grading system used for melanomas?
So you have the Clark, and then you also have Breslow's.
Do you recall the detail? What is Clark specify and what does the Breslow specify?
So Breslow's in terms of the thickness and tells you the prognosis for in terms of that, and then the Clark tells you the depth at which the melanoma is located or how deep it goes into your the different levels of your skin.
Okay. And in regards to antibiotics, do you know what is ESBL and what antibiotics you would avoid in that situation?
I'm not too sure about that.
That's all right. Give a quick read on that X-ray.
So you have you're looking at the right olecranon region, and you have a displaced fracture noted to the right elbow. That's as I believe it's also comminuted. You can see some small fragments in that area as well, and an increase in soft tissue density located in the elbow region of the right arm.
Good. Describe the fixation here and give us a speculate on what may have been done.
Yeah. So in this one, it looks like there was. Wait 1 second. Let me move this. So you have, I believe, possibly a medial calc slide, and you're fixating it with the. I believe those are pins that you're fixating that with, but probably not the best read, but that's what I got for this.
Why do you take pins instead of screws?
Just because of the length and diameter of the fixation that's being used. It doesn't look like the normal size of the screws that we would normally use.
Okay. Do you see any abnormality here?
Possibly on the ulna, it seems like there's an exostosis noted in the distal region of the ulna, but otherwise I do not see any dislocations or subluxations or fractures in this image of the left hand, of the left wrist.
Give us some differentials for this X-ray.
You can that could possibly be a unicameral bone cyst, a giant cell tumor, intraosseous lipoma, or possibly also a aneurysmal bone cyst as well.
Very good. All right, thanks for going through that one, David. I think that I put more ortho in there than I thought I did.
Yeah.
Really well done. These tend to be hard. So there are a few different types of interviews I think you'll get, right? There's elective, there's trauma, there's emergent, if it's emergent trauma or POST case. And then a lot of places like to do these rapid fires too. The rapid fire can be a little bit more difficult just for the sheer fact that it can be very random and all over the place. And you don't really get in the sync of the same way you do as a case. So it's a little more difficult on these because each slide is basically a new case for you, right? So treat it as such, meaning if you're hung up on the last one, forget whatever was, if you missed it, you missed it, just move on. Be quick to move on. And I think you did a really great job of that. This is a great way to get kind of a background of your knowledge in general. But these will be challenging. So I thought you did particularly well for the difficulty level here. It's basically just to let you know that this is another type of interview you could expect. Anything from the panel before we'll quickly just kind of go over the images?
Yeah, David, thanks for putting yourself out there. Like, these are easy when you're not the one in the hot seat, right? Right?
Yeah.
Like, you had the other people looking at it, but it also shows, that I bet half to 80% of the people looking at these X-rays are like, crap, I don't know what I would say. I need to go read up on that, right? And it really showed you're really strong in the clubfoot. You're great with tumors, right? You're just going to have to go back and look at how do you read MRIs, right? How do I read pediatric X-rays? How do I describe my fixation? So it really shows you where you're strong at, and so it's a great tool to really kind of show your weaknesses. So I appreciate you doing that.
Thank you, Dr. Cobb.
Yeah.
Good. Yeah, we'll just quickly go through these. I really do agree. That was a job well done. So for this one, we're looking for, maybe this isn't the perfect oblique kind of fracture of the distal tib. We're just looking for plate function. So know your plate functions. Is it anti-glide, buttress, neutralization, tension? Those are your plate functions through AO, right? Okay. This was really impressive. You nailed that one. Long thoracic, nicely done. That shows me that I really like and appreciate an understanding of anatomy, regardless of where it is. So I think if you know long thoracic, that shows me you damn sure would know the foot. This one here just gets you to speculate what could have been done. Yeah, it's a mid-foot fusion. One thing that maybe you did here, David, and I encourage you guys not to do is try not to overread them. Just give them what you see. Okay. So if you see a midfoot TMT fusion, then just call it that. You kind of started going down. You said some screws are in the navicular. You said some are coming from the cuboid. Those aren't affected here, right? So yeah, the less can be a lot more, honestly, in these. Okay. And again, this is just to throw you off. It's a broken hip. So definitely you did a nice job on picking up the arthritis. Right, but it's a neck fracture. So this neck fractures, they can be nailed. Maybe you can do a total hip. That you don't need to know whatsoever. I just wanted to see what you picked up here. And then nice job here. This was STJ fusion. I don't know if I know the size of the screws. So again, try not to overread. The screws can be whatever they are. You can describe if you see a fully threaded, partially threaded. You can tell us where they're going and what they may be doing. Reasons to fuse an STJ could be trauma, right? Could be arthritis, any of those things.
Can you go back on that real quick?
Good job here, picking up this one as well. A previous implant, so fusion's definitely a great option. There you can do a revisional implant, you could do a total implant. Just want to see what your thought process is.
So yeah, when you see options, just make sure you go through all of them, right? Even though, yeah, maybe not a revision implant or a Keller would be ideal, but still list those.
Okay. Hey, Paul, can you go back to the SCJ Fusion one? Mm-hmm. Yeah, I just want to comment that usually when we're looking at, even when we're doing hardware removals, we typically look up the op note to see what type of screw and what size. So I would be careful not to mention the size of the screw, because it could be a very small foot or a big foot, and the screw size relative to the foot may not be what it appears to be. You could also mention that there was a washer used in the superior screw, with regards to whether it's a solid or a cannulated, it's probably safer not to mention, but you can see the fluted tip on the inferior screw, which tells us that it's probably cannulated. So unless you mention that you can notice the fluted tip, I would just kind of guess that you're just probably guessing with regard to if it's a fully threaded or solid screw, if that makes sense.
Yeah, I think that's good, Chu. And just adding to Dr. Haas there on the big toe fusion, can you go to that one, Paul? The programs are just looking for your breadth of knowledge, David. That's all they're doing. So even though I agree. I think a fusion might be the best procedure here. That program might not agree. They might think, they do a lot of total implants, or they do a distraction arthrodesis, or they do a Keller. So they want to see what you know. So, maybe you put forth your most confident answer and then give them a good differential. That'll show them that you've read up on that.
Okay.
This is just again to throw you off, right? Crystal Violet, and
Yeah.
I don't think I would remember that either. This is a long time ago. That might indeed even be undergraduate level, right? But just to pick up, you can even just describe what you see. If you say, well, I'm not sure about what are the stain and counter stains, but I do recall from my from histology that I can see some purple rods. I see pink cylindrical type shapes. This could be this kind of bacteria. This could be gram-negative rods. This could be gram-positive cocci, whatever it might be. Can give you at least give you a little something here.
Yeah.
This is a tough one. This is this is an advanced case here. Again, just to see what is your thought process. This is probably beyond first year residency. So joint sparing things could be realignment type of osteotomies, like a supramalleolar, right? Tough case. But again, just to see what's your thought process.
So if you give them the right answer on this, Paul, or what you're looking for.
What do you mean? For the thought process?
Yeah, well, just the joint. So there's joint sparing and joint destructive type procedures out there, and I know you mentioned total ankle replacement. We still consider that somewhat of a joint destructive type procedure, both our total ankle and our ankle fusion. But other joint sparing type procedures could be a syndesmotic fusion, could be an arthrodiastasis, could be a supramalleolar osteotomy, as Dr. Whitehouse talked about.
Fibular distraction.
Mm-hmm. Cool. And then this is just kind of a it depends on how much you read. So if this was something that was particular of interest to you, maybe you'd know which implant this is. This is the Zimmer, just because we see the fibular plate. That's one of the big clues here, along with the rails, obviously. But again, it's not every residency does these, and you don't have to know these. It's just, again, it gets us an idea of your depth. Nice. I thought you did a nice job on the Castillo-Anderson classification. C, if you remember, though, is an injury to a blood vessel, which that you would have to ask me if there was any arterial injury on this one, which there wasn't. So this would have just been a B. Okay. 3B. But nicely done. You killed the clubfoot question. This one's tough. These are the cases I really hated doing interviews. Was anything tumor-wise. I think you have a great background of knowledge of tumors in the foot and ankle. So the only thing you didn't have perfectly down on this one was a read. So those MRI terms of outside of things like anatomical location and what might be involved are, is it hypointense, hyperintense? What's the nature of the lesion? Is it uniform? Is it geographic? Just kind of those descriptive terms. So to have a differential, I thought was really impressive, but the read you could probably give us a little bit more information on. Okay. This is, again, it's just a crappy x-ray to get you to think. I think this was actually a polio patient. CMT, I thought, was a cool diagnosis too, though, because I mean, you might see some of those crazy cavus foot and arthritic changes. It looks like this patient has had procedure in the past, so it's just to get you to think and show us what's going through your mind as you're working up an x-ray.
Yeah, just take note that does it seem like the fibula is still there, or like the lateral-malleolus?
Yeah.
Mm-hmm.
Yeah, so it was probably taken down for a fusion, and the hardware was removed. Is one answer to give here too.
And then again, medicine, you may get some random medicine questions thrown in. You got this right. That's primary hypothyroidism. I think chest X-ray is reasonable for your bacteremic patient, but specifically a TEE to look at the heart valves is important on these ones too. That's medicine stuff. Grading system, you got the historically Breslow and Clark is used. I think more recommended now is just the American Joint Commission on Cancer has a way to grade these melanomas, but definitely knowing both, because I think both of those will come up in your interviews. And then this is just a tough antibiotic question. So these are those extended spectrum beta lactamases, which affect certain cephalosporins.
Yeah, go back real quick.
Yeah.
Does anybody else know like why we order echoes for bacteremia of the heart? Anyone on the panel or on the interview list? It's sort of important for whenever we have diabetic foot infections. If they're bacteremic, you want to sometimes echo is ordered just to rule out infectious endocarditis, or if there's like a vegetation in the heart valve.
Mm-hmm. Great read here on the ulnar process fracture. That was really good. Yeah, I thought that was above and beyond, and even commented on some comminution here.
Thank you.
Again, that's just working to throw you off. This is definitely a tough one. I think you got the procedure right for sure. The reason there's pins instead of screws there, though, is that growth plate that's present, right?
Okay. Yeah.
Again, another one to throw you off. Here, it's a radial fracture.
Okay.
That's what we see right there. So just a little step off, and it's the same as if you pick up an ankle fracture. You'll see there's a step off into the joint. So I think you did a good job just reading it in general, and you gave the negatives which you saw. If you picked it up, that's even more of a bonus. And then you nailed this one. I don't think I could think of any more differentials for that one than what you gave us. Very well done. Cool. That's that one, guys.
Thank you, guys. Thank you, Dr. Whitehouse.
Nada. Okay. All right, who got up next? Brandon. Brandon, thank you. Thanks again for joining us today, man. Would you be able to give us a little quick introduction of who you are, where you're from?
I would love to. And also, I want to thank you for allowing me to be a part of this. I've already learned a lot just from the last two students going. And I don't think I've met any of you before, so it's nice to meet you, Dr. Haas, Cobb, Chu, and Whitehouse, and if I missed anybody else. And my name is Brandon Myla. I'm originally from Seattle, Washington, and I go to Western University. I'm currently living in LA. Before medicine, I was working as a sterile processing technician for 12 years up in Seattle, Washington, as well as Arizona. And currently I'm living in LA, and I love the weather here.
Cool. All right, Brandon. So we got a case for you today. Let's go ahead and work through it.
Sure.
I'll give you the background here. It's a 66-year-old male. He's got a past medical history, which is significant for diabetes with peripheral neuropathy, some peripheral vascular disease, hypertension, hyperlipidemia. We're coming into the ED with 1 week of worsening discoloration malodor to the right foot. Has a long-standing wound to the same area, but has never really followed podiatry for this issue. In fact, they just saw their primary care physician who placed them on Cipro for this issue.
Cipro.
So before we get further into the case, let's talk about Cipro. What changes can that make to an EKG?
I actually do not know what changes Cipro can make. Looking at this one, though, it looks like this is a bradycardic. And then the norm, so I don't know, could be that. There's also, yeah.
What are the normal components of an EKG?
So you have the P wave, the QRS complex, and then you have a ST, and then sometimes you have additional waves too, U, delta.
Okay. Do you know what does the QRX complex represent?
That represents the ventricular or ventricle pulses, the electrical pulses that go through the heart during systole.
Okay. A little bit more medicine. So let's work through these. Follow my cursor. So which goes in each one?
That is sodium.
Below.
That's chloride.
Here.
No, wait, sodium, that was potassium, sorry. The next one is chloride.
Mm-hmm.
And then CO2.
Okay.
BUN.
Okay.
Creatinine.
Okay.
And glucose.
Very good. What's the normal potassium?
Normal potassium is, I believe, not sure, I think it's around, not sure, I'll have to get back to you on that one.
No problem. What do we have here?
That's white blood cells.
Here.
Platelets.
Okay.
Hemoglobin. And hematocrit.
It's a normal male hemoglobin.
Normal male hemoglobin, I think, is 12 to 16.
All right, let's get back to our patient here. So here are their vitals. Looks afebrile, blood pressure slightly elevated, heart rate 83, respir 16, setting 96%. Not really in much distress. They have no palpable pulses, like gangrenous changes to the toes. Obviously no sensation with their long-standing diabetes with peripheral neuropathy, a mild bunion. That doesn't really matter too much in this case. And then dermatologically, we'll get to see the patient here in a moment. So here's some labs for you. You want to comment on anything here look abnormal to you or concerning at all?
Yeah, the A1C is elevated. The sodium looks to be slightly decreased. Creatinine is a little bit elevated. Glucose is extremely elevated. And white blood cell is also very high. RBCs is low. Platelets is normal. And neutrophils are high.
Good. Can you estimate with that A1C what this patient's daily glucose may be?
For 9.7, that would be, without writing down and doing my little cheat thing, I would think that's 220 around.
All right. Can you describe what you're seeing here clinically?
Sure. This is a clinical image of the dorsum of the right foot. I'm noticing darkened skin along the metatarsophalangeal joints distally. It appears to be ischemic. There's also xerotic tissue all the way up to the level of the ankle, and I cannot see any further. I'm sorry, I'm gonna lean it a little bit. My laptop's a little small. I don't notice any open wounds or drainage at this time. There might be some edema, but I cannot tell. And there also does not seem to be appreciable erythema on my screen anyways. And
so is there a classification you can give for this foot?
yeah, I can use the Wagner for this one. This would be the 4-foot gangrene, which is a Wagner 5, I believe.
Good. Give us a quick read on these images.
Sure. These are lateral and an AP of non-weight-bearing right foot. Looking at the AP, I'm noticing decrease in soft tissue density under the 3rd, 4th, and 5th med heads, indicative of probably an ulceration. And normally shouldn't do biomechanically and non-weight bearing, but it appears this patient actually is very metaductus. There also appears to be erosive changes to the 3rd, 4th, and the medial aspect of the 5th metatarsal head, and diffuse erosions of the 3rd and 4th. I do not see any signs of loculated emphysema. I also do not see any foreign bodies. And I do not see any other soft tissue abnormalities besides the ulceration, except for there could be some, looks like sclerosis of the, maybe the dorsalis pedis as well. And I don't see any fractures. Looking at the lateral, I see what appears to be decrease of soft tissue density above the metatarsals, and this could be emphysema as well. This impression is this is could be gas gangrene, but I'd like more imaging and studies to find out.
What images or studies would you want?
I could use, for this one, I could use a bone scan. I can also use CT or MRI. And then I'd also like to get cultures.
Okay. What type of cultures?
I want to do aerobic, anaerobic, deep wound cultures.
Any additional ED labs, images you want?
Yeah, I would like ESR CRP in addition to, this is a female. Yeah, I would like to know her tetanus status as well as I want to know her pregnancy status if she doesn't know that, or she had something that would preclude her from not being able to get pregnant. I'd get a UA as well. Because I believe she was like 40 and female, maybe. It could have been.
Okay, so in this patient, what's your diagnosis, what's your antibiotic therapy, and what's your surgical plan, if you have one?
So from the labs and the radiographic finding that I found, this appears to be an infection. I'm not sure as of right now, the severity of it, but I would like to put her on broad spectrum, probably vancomycin, and then a surgical plan. I'd like to take her in as soon as possible, and I would do an IND and most likely resection of the 3rd, 4th, 5th med heads due to the possible osteomyelitis. And depending on the soft tissue coverage, we might do a TMA. I would just go proximal until we.
What would you say here, Brandon, if she had a severe penicillin allergy for your antibiotic choice?
She had a severe penicillin allergy. We can use clindamycin.
Okay. So this is what was done. Can you describe what your findings here?
Sure. These are 2 non-weight-bearing radiographs of the right foot. Appears to be post-operative due to the splint artifact in the lateral. It looks, it was a proximal TMA with it does not appear to be closed either, completely closed. It looks like the lateral aspect of the TMA was left open. And don't appreciate anything else in these radiographs.
Good. So let's do some quick discussion here. What is SIRS criteria?
SIRS criteria, that's systemic inflammatory response syndrome, and it's a white count greater than, I think it's 12, and then it's heart rate above 99, it's respiratory rate above 22, and then it is forgot the fourth one. I know there's a fourth one and you need 2 or more for that. I'd use MD-Calc to find that one real quick. And sepsis is SIRS criteria plus a source of infection. QSOFA is used inpatient to also evaluate for sepsis. And what the most, so for gas gangrene, the most common one is Clostridium perfringens, but the other Clostridiums can also cause gas gangrene, as well as other gas-forming bugs such as I think Bacteroides and Provotella.
Good. All right, thank you, Brandon. Nice
Thank you.
All right. Any comments first from the team here? We'll work the case together real quick. This is Chu's thing here.
I think you're up, Chu. Yep.
Yeah, I'll just go through it again. I'll comment on all the way.
All right. Well, a nice start, Brandon, with kind of giving us a little background on yourself here. So, like I said, 2 big or major types of interviews: trauma, elective, and then infection is one. You just have to know it. That's what you're going to take call as a first-year resident anyway. So, having a really good understanding of when a patient who is sick needs to come into the hospital and may need surgery. So those are your big pickups I think would be important to convey to residencies that you're able to find and see. Again, this is medicine review. Cipro is a common one we use. It's got another, so it does cause QT elongation, which can cause a fatal heart arrhythmia. It does other things podiatry related to, which we didn't ask you, but it can cause tendon rupture, right? That's one of its black box warnings. The normal components, I think you got P wave, QRS complex, T wave. That's just medicine stuff. So atrial depolarization, ventral depolarization, and repolarization for that T wave. Here, this showed a good knowledge. You got, in fact, you got all these right. The values may be a little less important. You know, they're given to you in the labs, and they may actually differ slightly from hospital to hospital. So just kind of knowing that background knowledge of general findings, I thought was important. You did a good job on those. It shows some good medicine background. So here, this patient was relatively benign except for their X-ray, which is this is meant to throw you off. They had, which we'll get to, they had gas on their X-ray, which you know is an emergency. But their vitals were kind of boring, which you will definitely see on your uncontrolled diabetics or vascular paths. They just don't respond the same way maybe you or I would to such a severe infection. So really no temperature, really no heart rate. They would probably mildly fit into SIRS criteria. Actually, I don't even know if they would from what we gave you. This is just meant to make the case a little bit more challenging. So you did a nice job here on picking up the abnormalities. A1C is a good measure of your patient's ability to heal after surgery, I think, and then just their level of uncontrolled or controlled nature of their diabetes. I like to use something really stupid and simple for A1C estimation of glucose, which is just the rule of 20. So take your A1C, round it to the next nearest number, multiply it by 20, and then plus or minus 20 in either direction. That's what their blood sugar will be. So that she's going to be anywhere 200 to 240 or 180 to 220. That's just a quick way to do it. You picked up well here on the elevated creatinine, and you also got the white blood cell count. So both of which are important. The other big thing here is sodium, which may help you with if you use the laboratory assessment for neck batch. Nice read on this one, Wagner 5. That's kind of an obscure thing. We tend to get really focused on the remembering trauma classifications. So you did a great job on this one. Anything you would add to Brandon's read?
Yeah, so just realize that in general, skin on erythema on black skin or darkened skin doesn't really come out as red or pink erythema. It's usually dark, like darkening of the skin. So you can see kind of like a V-shaped erythema tracking approximately towards the midfoot on the 3rd, 4th, and 5th. Do you see that? A little bit of a dusky triangular shaped erythema. Even over the 1st, there's a little bit going on there.
Maybe.
Yeah,
it could be my computer too. I don't have the greatest laptop. But yeah.
Sorry, Paul, keep going. I'll be right back.
Okay. Cool. Yeah, and then here the big thing, Brandon, was there's gas. A nice pickup on the erosive changes to the metatarsals. So this is the point where you're looking at the patient. I don't know, maybe it's stable gangrene. His labs are kind of, he's got an elevated white count, but otherwise he's a little bit boring. But then you get to the X-ray, it says, all right, this guy has the potential to lose this limb now. We need to do something about it. So this is what should kick your gears going as far as planning surgical and admission and things like that. And then antibiotics, those will certainly come up, have some good backgrounds. I think you gave us clindamycin. So clindamycin, that's got pretty good like gram-positive coverage, but what about your gram-negatives and anaerobes? You want to have options for that. So do you know any of those, Brandon?
Yeah, we could added Zosyn or metronidazole for the anaerobic one.
Yeah, perfect.
And Zosyn for gram-negative.
Just to give you a tip there, when I look at broad spectrum antibiotics, typically as a podiatrist, you're a consultant, you're not going to be starting it unless you're primary admit, which is usually at VA programs, you'll be a primary admitting, so it'll be helpful if you're going to a VA program to know your broad specs. But in private practice or even in hospitals, usually we're consultants, so you're not starting it. But kind of like a rule of thumb is Zosyn is a good starting point, and it covers Pseudomonas, with the exception that if they have a penicillin allergy, then you have to know a backup. So a backup, like my go-to answer would be Vanc ertapenem. Only problem with ertapenem is it doesn't cover Pseudomonas, so you'll just have to add a Cipro if you're suspecting Pseudomonas. But that's kind of what we're looking at when we're thinking about broad spec and antibiotic choice in the conflict with allergies.
Cool. And then again, that was a good read here. I liked your pickup on knowing that this was still open. You didn't say this patient still has gas. You could tell that this was left open to drain, right? So nice read there. And then these are big things for the pus cases. You've got to have these down absolutely cold. So SIRS criteria, that's a definite need to know, right?
Mm-hmm.
Anybody on the panel want to give us those quickly?
I forgot temperature.
So SIRS, so white blood cell, it's going to be less than 4,000 or greater than 12,000. Your respiratory rate is going to be greater than 20. Your heart rate is going to be greater than 90, and then temperature is less than 36 degrees Celsius or greater than 38 degrees Celsius.
Good. Do you remember it in Fahrenheit?
Wait, what was that? I'm sorry.
Do you remember those numbers in Fahrenheit?
So would it be 101.1 degrees Fahrenheit greater than that?
101.8.
Yeah. Or 100.4?
Oh, 100.4. Okay.
Or less than 96.8.
Oh yeah, 100.4. Yeah.
Easy way for me to remember is that your normal is 98.6, so you flip those two numbers, 96.8, like below that. But usually we don't count sepsis. Like rarely do you see sepsis where the numbers are going on under the low end. Usually it's on the high end. but just for memorization purposes, that's how I memorize it.
Yeah, definitely. And then, so sepsis is a definition. I think you gave a good general definition. There's newer SIRS criteria papers are published. We may give you some more detail on that stuff. That could be worth reading. But just in general, knowing what they are. QSOAP is a little bit newer measure. You did a good job picking up that that's used in hospital patients to determine how sick they are, and really can give a great estimation of what their morbidity, mortality could be in the hospital. There are 3 components to it. Anybody on the panel know that?
So you have respiratory rate, you have blood pressure, and you have altered mental status.
Shit, confusing. All right, thanks, David. I'm not sure. We kind of froze here for a second, but yeah, respiratory rate, altered mental status, and then systolic pressure. Those are the QSOPA. And then last thing here, Brandon, was organisms commonly responsible for gangrene, which I think you got. Many different things can actually cause gas to present. These are often polymicrobial, obviously, too, with long-standing dead tissues.
Here's a kind of question just to throw you off, but there was non-palpable pulses, and in the setting of gangrene, you'd be concerned about blood flow. What would you order to work up the blood flow?
I would order Doppler, ABIs, TCPO2, and then get a vascular consult while I'm doing that too.
Okay, so the toes are black and you're probably not going to get any read on it. What
No.
else can help you with assessing blood flow that vascular docs would look for?
Besides the ABI, or
yeah,
so we could do duplex ultrasound.
there you go. Yeah, arterial duplex. That's a lot more helpful than an ABI is, because ABI you can have calcified vessels that you picked up on the X-ray, so they could be falsely elevated in the setting of a severe infection where all the toes are, not doing too good. You might not be able to get some of the information you need with classic, the other things that we're normally taught. But usually all my vascular surgeons, all they really need is arterial duplex. You can look at the quality of the ultrasound. You can look at velocities and look for stenosis through the ultrasound. That's a lot more helpful than ABIs are. And the last question is, so if we're concerned about blood flow, would you want a vascular consult and evaluation first before you do some type of podiatric intervention, or would you go for that TMA right off the bat?
I would go for the IND potential AMP due to the seriousness of the gas infection.
Okay, good. Yeah, with even in the setting of peripheral vascular disease, you definitely want to get source control, especially if there's a somewhat aggressive infection such as gas gangrene. And yeah, good job. I just want to make sure you get that.
Yeah, thank you, Brandon. That was the job nicely done on a tough case.
Thank you so much for having me.
Chu, we have anybody else with us today?
I think Abhinav.
Yes.
Abhinav, are you there?
I am here. Can you hear me?
Yeah.
Yeah.
Awesome.
Thanks for joining us. There you are. Much appreciated. So we'll have a case for you today as well. And would you be able to just kind of introduce yourself? And,
Yeah, sure.
Thank you.
Yeah, my name is Abhinav Flava. I'm a 4th-year student at the California School of Podiatric Medicine. Originally from El Paso, Texas. Currently in Albuquerque, New Mexico for my core rotation and dealing with like a back injury and a concussion right now, but it's all good. I'm very active in the political and legislative efforts of podiatry. And I'm also a national delegate for the American Podiatric Medical Students Association.
Nice, cool. Thanks for doing that for the profession. That's awesome. And thanks again for being here today.
Thank
All
you.
right, let's get you going here. So we've got emergency room call situation. Here you have a 48-year-old female coming in with right leg pain. She said she was in a motor vehicle crash. Doesn't have any other source of discomfort. Did not lose consciousness. It's simply an isolated right lower extremity issue. She does have a past medical history of RA with a heart block, fibromyalgia, multiple myeloma, hypertension. There are medications here. She's allergic to sulfa type drugs. Real no contributory social history in this case. So let's do a quick medicine review. How can you differentiate RA from OA on clinical examination?
Yeah, on clinical examination, I think RA, you have like the symmetrical, like sclerosing of the joints. What else? You have that little pannus looking thing that goes around joints as well. Lab wise, you can order like you see like a rheumatoid factor on it, and then on imaging, there's more like joint destruction with osteoarthritis, and then you have like, when you're looking at it as well, like a severe case of osteoarthritis compared to rheumatoid, you have those Herberdens and Boutonniere nodes as well. So that's one way I could see in like, I guess like a presentation wise.
Good. So she has a history of multiple myeloma. Do you know how that's diagnosed and what that is?
I'm not sure about how it was diagnosed. I can't recall it right off the top of my head.
Okay. She's on losartan. What was she on that one for?
Losartan, I know that's angiotensin drug, so it's probably like really blanking right now, but yeah, I just know that losartan's an angiotensin receptor drug for hypertension. Sorry.
There you go. Good.
So
a couple more medicine questions. She has a heart block. Which one of these shows a heart block, and can you identify what type it is?
The top one shows a heart block. I can see that the P wave gets, unlike that first one, it gets longer, and then it drops it, and then it gets shorter. So I think it's type 1, maybe a second, like a secondary AV block.
Good. What does the bottom EMG or EKG show?
I believe it shows like an ST elevation. I'm not too sure.
Good. All right, let's get back to our patient here. So stable overall. She's just having some pain and distress secondary to that. Her dermatological is normal. She does have palpable pulses. Protective sensations also still intact here. She does have a gross deformity, however, with pain throughout. What's next for this patient for you? Do you have questions or labs or images that you want to see here?
Definitely get some x-rays. Let's see, for labs, I definitely just order like the whole bulk, like CBC, base metabolic panel. There's no infection going on, so I wouldn't really deal with ESR, CRP going right now. But definitely some x-rays, some radiographs.
Good. All right, so here's some first initial set of imaging. Could you give a read here for us?
Yeah, so this is a right AP view of the right ankle. Definitely see increase in the space between the fibula and the tibia. And then there's like on the lateral non-weight bearing view, I do see an anterior dislocation of the tibia as well. So is there any additional imaging? So I can probably see. I don't see any comminution or any bone fragments in between. So.
Okay, what's your next step here? What do you want? More imaging, or what's your plan?
My plan, if it was an ED right now, I'd probably try and reduce it to like look like a little closed reduction, and then probably splint it with like a posterior splint or a Jones or something, just to keep it in nice form before we could like take it into the operating room. One thing I did forget to mention is there is some skin tenting going on. So I don't know if there's any fracture blemishes or anything like that going as well. Also just noticed that on the fibula, there is like this, I don't know if that's like a little spike or anything like that, but I'll definitely take that in consideration on a CT or something. It might be intra-articulated. So might be able to pick it up on a CT.
Okay, so her skin was intact. She just came in acutely. So what's next for you? More imaging, or what's your next step?
After closed reduction, I'd probably get a CT just to, because I know that there's a lot of disruption in the ankle joint. So just to make sure that there's not any fragments or anything left behind. So that kind of helps me with the surgical procedure of what I need to plan out.
Okay. So closed reduction was performed here. These are your post-reduction films. Can you give us a read on these and make any comments on findings?
Yeah, I don't see any radiolucency of the fibula, but I do see a radiolucency of that posterior malleolus. So on the lateral view, and then no additional findings from what I see.
So what would be your, say you're calling your attending on this one, and what's your diagnosis? What's your plan?
My diagnosis would be initially right ankle dislocation with a posterior malfracture. It looks like it's less than 25%, so probably doesn't need any fixation. But since there was that little syndesmotic injury, I probably would plan for stabilizing that syndesmosis either through screws or like a tied rope or something.
All right. Cut out for us for a second there, Evan. I think, sorry about that. But any additional plain film images you might be curious to see here?
Probably a medial oblique. I could probably get that, or upper, yeah.
There we go. How about here? Can you make a read?
Yeah, that's a Maisonneuve fracture of the fibula of the right fibula.
All right. So with everything we have here, what are you doing with this patient?
Probably, like I said, closed reduction first, and then probably an RIF just to fix the syndesmosis, and then probably get like a fibular plate to fixate that fracture and also bring out that fibula out to length.
How are you fixing the syndesmosis in this case?
The syndesmosis, I'd probably throw 2 syndesmotic screws, like I think the textbook answer is like 1.5 to 2 centimeters above the ankle joint.
So that's what was done here. Can you describe what you see?
Yeah, I see 2 syndesmotic screws with 2 washers as well on them, 1 on each syndesmotic screw to superior and inferior screw. Yeah, it looks like it was syndesmosis is corrected, and then the tibiofibular overlap has been achieved. The ankle gutters, the clear space is all within normal limits now. It's all around medial clear spaces around 4 millimeters or so, and also the lateral and anterior or the portion of the talar dome as well.
All right, let's do some general discussion. What are the principles of AO?
The AO are reduction, anatomical reduction, and then rigid fixation, atraumatic technique, and then early mobilization or range of motion.
Good. Can you review one more time for us the steps in placing an AO by technique?
Yeah, it'll be under drill, over drill, countersink, measure, tap, and then screw.
Good. What are some differences between cortical or cancellous type of screws?
Cortical screws, the pitch is a lot more tighter, and then cancellous screws are a lot wider, and then they could either, both of them could be either partially threaded or fully threaded.
Okay, what's the primary assessment in the trauma patient?
Not sure what you're asking right there. So what is
So
involved?
for a patient who's involved in a trauma, what?
Oh, okay. The ABC, so airway, breathing, and circulation. Not too sure.
Good. All right, thank you. Nicely done. And any general comments from the gallery before we'll work through this one again?
Yeah, one comment. I liked that you, after your initial read, you discovered some skin tinting and you just went back to mention that. I think it's totally fine to do that. You know, when we're looking at x-rays, we're sometimes going back and forth to in real life. So, you know, this is an interview. You don't have the luxury to zoom in and change contrast and go back and forth. So, I mean, in my opinion, I think it was fun that you did that. And I kind of like that you did that.
Yeah, I mean, I know I'd like to hear what Dr. Haas and Whitehouse think as well, but I know when I was getting ready for interviews, there were things that I always looked on an x-ray that I wanted to make sure I never missed. And in infection cases, it was gas. You know, I'm definitely not an infection expert. That's why I would choose around. But that was number one. Two is any trauma. I always looked at the midfoot complex to make sure I didn't miss a Liz Franks. I didn't want to miss that. And then we get into like crush injuries like compartment syndrome and coalitions. But another one is, you mentioned it twice. You said, I don't see a radiolucency issue on the fibula. And that should be your big clue, right? You got a dislocation of an ankle. A pure syndesmotic injury with no fracture is almost unheard of. They happen, but they're very rare. And so if you have an ankle fracture, there's got to be a fibular fracture somewhere most of the time, right? So just, especially if there's a syndesmotic injury. So just keep that in mind. That should be one of your checklists that you don't want to miss.
Cool. Yeah. All right. So this is a pretty standard patient, right? An ankle fracture maybe is a little bit more difficult case than a bimal, but principles, again, they're totally the same in your workup here. And we just bring in some of these medicine questions to throw you off and see what is your background knowledge, right? I think you did a fantastic job on the RA versus OA. I think that's a pretty difficult question, and you did a nice job on differentiating between those two. You don't really need to know multiple myeloma. It just shows maybe your breadth of knowledge of medicine. So that's plasma cell cancer, which is diagnosed with a certain type of blood exam. And then losartan, you work through it after a bit, but definitely used for hypertension, and you got the receptor mechanism correct as well here. So these, again, just meant to throw you off. If you just know what are the normals on an EKG, you can possibly work through it, which I think is what you did here, right? So you picked up that one of these P waves didn't send off another QRS complex. So you're exactly right. It said type 2 AB block or type 1 secondary AB block. So very well done there. And then here we're just pointing out tinted T waves. So sometimes what happens on these is the more you answer, the more you might be asked as well. So if you told me tinted T waves, then I'm going to ask you, well, why in this case might she have tinted T waves, or what lab finding can clue you into a potential for a tinted T. So I thought you did a good job there too. Just patient background. I think you asked all the questions you needed to know. I like that you, before I asked you to get x-rays and labs, you said it's a trauma case. I don't need to go get a bunch of infectious markers and things like that. I just want to see the patient. I want to work them up, and I want to see their imaging. So I thought that was very cool. And then, yeah, here, I love Dr. Cobb's points to the stuff you don't want to miss on an x-ray. You did a pretty good read. Sometimes these take some work, and maybe you'll circle around to what ultimately the diagnosis should be here. Just try to be uniform with your read, right? If you're someone who likes to work soft tissue to bone, that's cool. If you like to work distal to proximal, that's fine. If you want to solely go to where the pathology is, just have your method down and be very practiced with it too. So yeah, you picked up on the dislocation here. You made mention to this this artifact, which appears to be around the fibula, which I think later, obviously, you saw was that posterior malleolus, right? So nicely done there. And then closed reduction was performed, so that makes the read a little bit more simple in this case. Now you can really make up that posterior malleolar. This is the point where I was hoping you'd tell me, all right, maybe there's more to this ankle. So it's, you know, CT, I think is reasonable when you have high energy trauma. That's not wrong. Just have your reason for why you want to do it. I want a CT scan because I want to assess the joint, or I like a CT scan with all my posterior mals because that's going to tell me if I'm fixing this prone or if I'm fixing it supine. That's totally fair. Just have a good reason. But I was hoping you'd ask me, let me see a proximal fib film for the likely mechanism here that allowed that dislocation. So that's what we see there. Maybe you could have been a little bit more descriptive on this one as far as the orientation of the fracture line, if there's comminution, if there's butterflying, if there's displacement, if it's non-displaced, whatever it may be. Just make sure you're mentioning those different things. And then get to the plan. Any other comments from anybody on the x-ray reads?
No, I agree with Dr. Whitehouse. Just have a plan. Just be concise. You're going to be asked to read X-rays probably in every single room that you go into for interviews, and just being able to have a game plan. And yeah, whether you're reading it from proximal to distal to proximal, and soft tissue to bone, and just systemically going through it in your head and being able to verbalize it. Describing fractures, describing malalignment, go through your displacement, go through your joint description from subluxation to dislocation is definitely important.
Cool. And then here, there's probably different ways you can do this fracture. I like that you said that fibular fracture didn't actually, did you say maybe it needed flated? But that's a stable pattern. We're addressing it with the syndesmotic fixation here. Maybe those details you don't need to know. It just shows a little bit further depth of knowledge.
Yeah, and as a residency program, I thought you did a great job. It's on the next slide, actually. I was beating Whitehouse to it, but you know AO really well. And so what a residency is then looking for is they don't have to take that time to explain principles to you. Once they're in the OR to fix, they can get to the next step. So that was great. I thought you did a good job with AO.
Yeah, that was perfect. So great background knowledge of AO principles. That's really, really important. And then, yeah, I think you got the primary assessment of the traumatically injured patient as well. So nicely done, guys. Thanks for everybody. I think that's our last case today. Any other comments from panel or any questions from any students out there for what we've gone over today?
I'd like at least like Dr. Zach and Paul and Chu just maybe to give some pointers on what they used for interviews and what they really like today and what programs are really looking for. I think that's really helpful to hear from people that are still teaching.
Yeah, one of my pet peeves is when you're looking at an x-ray, just know that we're all waiting for you to answer, and when you're staring at it for 20 seconds kind of thinking about what to say, that's 20 seconds lost from us getting to know you. We would love to hear your thought process. It's not about getting the right answer. We just want to know how you think, that you can think. We want to, even if you're looking at a normal x-ray, just tell us what you're looking at. Give us like kind of an insight into what's on your mind at that moment. Whether you're going through it in a systematic way, that's great. Like if you're reading a normal x-ray in a very systematic and articulate way, that's still really good points for me in my book, because then I can tell that you have your system down, you've practiced, I can rely on you to tell me that this is normal. So when you say, this ankle looks fine, at 3 a.m. when you're presenting to me on call, I can rely that it is truly a normal x-ray that you're looking at.
Nice. Yeah, no, candidates that really stand out to me are candidates that can read radiographs concisely and being able to verbalize it adequately to their attending, and also truly knowing your anatomy. There's, if you know your anatomy, everything else becomes so much easier. So same ordeal, verbalizing the anatomy, knowing which structures are important from the clinical presentation along with your surgical anatomy.
Yeah, I agree. Every residency has its personality. I think you have some that are laid back, some that are really high strung, and then all those in between. So the personality, hopefully you got to know when you're out on rotations or as you've done other mock interviews and things like that. But for candidates, I just want to see that they have a thought process, that you don't have to know the answers yet, that these have 3 years of residency to learn everything. So just show that you can work through something. One of my pet peeves of the interview is guessing. So reading an x-ray and saying, I think I see this, or I maybe see that. I just don't like that. I think just say what you see, right? We're not going to see the same thing, and we wouldn't even describe it the same, most likely. So just say what you see, move on, try to be concise as you can. Less can be a lot more with these. And just try to let your personality come through too. It's going to be a little bit different this year and hard on you guys. So hopefully what we're doing today can help you somewhat get ready for that. As far as prepping goes, prep materials, that's what your rotations are for. Really simple and effective things. I love that Prism book that is out there, the podiatry residency interview manual, whatever it is. That was a fantastic resource because it just gives you a background of here's what potentially could come up. And I worked through that many times, and I honestly didn't see anything on interviews that wasn't covered in there. And I just like reading papers. So maybe that, whatever you like to study, if you like to read a textbook, I think that will come through in your interview. If you're someone who likes to read papers because that's interesting to you, that will come through in your interview. But your general knowledge, that's from school, that's from rotations. And then one of the most helpful things I used was that Prism.
Yeah, I think those are great, guys. I tend to lean a lot with Dr. Z. Obviously, we train together, but I think if you can read an X-ray, it makes you so much more comfortable to proceed throughout the rest of the workup. Because if you get hung up on reading the X-ray, you don't really know where you're going to go. So I know when we were as students, we would read X-rays together and just throw them back and forth and then critique each other. And once you feel comfortable, it's one less part of the interview that you don't have to worry about. And so that's what you want to knock out, right? You want to have open fractures down cold. You want to have infections down cold. You want to have trauma down cold, like an ankle. And then the other ones you can get by, right? Because they're always going to ask you something you don't know. So get the standard stuff, very simple, and be able to read an X-ray. That'll set you apart. The attendings will remember the candidates that can read X-rays. I know I do. So thank you so much for doing this today, guys. And like Paul said, any questions or feedback from you guys? We don't want to take over this this interview process here.
Yeah, feel free to unmute yourself and ask a question or chat.
This is really great. Thank you all for doing this for us. This is super helpful. I really appreciated it. Thank you.
Thank you. Thanks to all of you for putting yourselves out there. You're in front of a bunch of strangers you don't know. You're in front of a bunch of students you don't know. So that was a huge step to do this. Hopefully this makes interviews seem like a breeze for you, actually.
I hope so.
Very cool. Well, I guess
have a question real quick.
Go ahead. Go for it.
these were all like really good cases. And I wish we could have went through all 10 of them, but I was wondering if you had any tips on the social questions.
Okay, that's a really good question, Brandon. I'll bring up a couple points on that. Those can be extremely awkward and they're weird to practice. The most common social question is, tell me about yourself, either in 30 seconds, 1 minute, 5 minutes. It depends on how long that they might give you. So be able to do all of those things. You may get weird questions like, what kind of sandwich would you be if you could be a sandwich? I don't know how that relates to if you're a good resident or not, but it can just kind of show you a little bit more of someone's personality, right? So some of those goofy questions, just be prepared for them. Prism actually has a list of weird social questions you could get asked. I don't know. My experience, I didn't see much of that. We didn't really do that through our program. But I've heard of those classic things like tell me a joke. So any of the other panelists have any advice on that stuff?
We want to see something different, right? Make us laugh, make us cry, make us inspired.
Yeah, be yourself. You can kind of come up with. It's nice to have like a somewhat PC joke in the back pocket to bust out whenever asked that question. Sometimes, on the interview committee, we're going through 20 or 30 people, and sometimes it gets a little hard to distinguish one from another. So like a unique joke true to yourself would be helpful for us to remember you.
I just had a quick question. I know that you guys mentioned earlier that there could be a possibility where the interview is just a case workup, and then you can also have like a rapid fire. Is there a possibility where there's a mix of that, or is it something where it's just like one or the other, or the different formats of interviews that could possibly occur?
Yeah, I would expect to see a mix. So
Okay.
yeah, you very well may get a case with rapid fire. You may have a strictly social interview as well if they know you academically. It's not in person this year, but there were during my interviews, I had interviews where I did a hands-on stuff, suturing, scoping, bone osteotomies, um, examinations on paper of questions relating to articles published by the people who ran the program, all kinds of different things. So yeah, it's certainly expect a variety.
Even as those case presentations that Dr. Whitehouse presented, he had some rapid fire questions included, right? Those medicine questions as well.
Thank you.
I think another good portion of the social interview is, if you guys have questions for that program, right? The more interest or background you have with the doctors in that program, or some of the papers that came out of the program, I think that shows your level of interest. Because as a residency, we not only want you, but we want you to be interested in us.
That's a great point. Yeah, and if you were fortunate to rotate, then if you can remember something personal of a patient, someone you worked with there, oh, how did patient X with the ankle dislocation we did that day on call? How have they been doing? Are they okay? Something that just shows your interest. Or I haven't been here since May. What can you tell me about the program that may have changed? Where you see the direction of the program going, and so forth.
I have a question.
Go for it.
So, this year is a lot different for both residencies and students. And I personally didn't get to visit or rotated as many as I, years before had. And I didn't get to personally know a lot of the places that I that I'll be setting up interviews at. How appropriate is it to ask more personal questions to the attendings during the interview process to get a feel for who they are with their residents? And is there certain things that I shouldn't ask when I'm trying to feel out the program?
Yeah, that's a good question. I think if I were you, I would probably do some of that before the interview, where you try and reach out to the residents of the program, like the chief resident, and request, see if you could schedule some kind of like chat with them or a phone call just to get a feel for the program. You know, we all understand the visitation rules are stricter in some states than others. So, you know, we totally get it. You know, 2020 has been a difficult year for many, many reasons. So I mean, you know, if a student was interested in my program and wanted to just chat with me about that program and talk numbers, talk like the experience that my residents will get, I'm happy to chat with you. You know, I usually, my drive is 30 minutes. That's 30 minutes. I'm free to chat every day with anybody, you know. We all can carve out time out of our day for stuff like this.
But I think it's appropriate to ask questions with regards to, you know, maybe not home life or this or that, but in terms of, you know, their dedication and commitment to their residency and how they view the residents and what they expect from the residents. I think those are appropriate questions.
Yeah, just tread kind of carefully with it, you know. I might like if you show up and say, hey, what kind of bourbon do you like drinking? But that probably wouldn't fly so well everywhere, right? But you can certainly ask them, you know, what's the culture like here? What do you guys enjoy doing? Or even if you haven't even been to a city, maybe you can ask them a little bit about what that city might have to offer and what it's like, or ask them questions on things you've read about it.
Yeah, one thing I just want to briefly mention and kind of sing Dr. Whitehouse praises is that I'm pretty impressed with Dr. Whitehouse's ability to read an EKG. I think that's definitely kind of going above and beyond with breadth of medicine knowledge. So I don't want you all to be thinking, oh, I need to like be, you know, learning how to read EKGs now on top of x-rays. I think definitely put priority over x-rays and some of the other basic commonly foot and ankle topics. And if you have time, learning to read an EKG, you know, it's not something you can just pick up. It's a few hours of work to put into it, and that's, to me, in my mind, extra credit to kind of show your breadth of knowledge.
Totally agree, Chu. That's never a negative point if you say I can go to the next question. Let's skip the EKG. It's a bonus point if you get it. That's all.
Well, thank you guys. I hope this helped, and I really appreciate Whitehouse putting this together, and Zach and Chu showing up. That's pretty cool to see you guys on here.
Yeah, thanks everybody. It means a lot to everyone who showed up today and participated.
Yeah, good luck in your studies. Use us as a resource, and if there's any questions, give us a shout out.
Yeah, Dr. Whitehouse, do you want to mention your offer for students who join us on the academy?
Yeah, definitely. So for you guys, as you're working the next few weeks into going towards interviews, I'm happy to do these on a personal one-on-one session. So any of those who end up joining, you can check us out, footanklsurgeryacademy.com. Any new members, just send us a message, and I'm happy to set up a personal one-on-one interview with you guys over Zoom. We'll do a post on Instagram about that as well.
All right. So yeah, I have this meeting recorded. I'm hoping it's still okay with all the interviewees who were, thank you for being open to participating and putting yourself on the spot. I know it's kind of nerve-wracking and difficult, but this will be a very helpful video for all those that couldn't make it to the meeting to be able to see this up on YouTube or Instagram. If you don't feel comfortable, send me a message and I'll edit it out. But I'd love to be able to put this full video up onto social media for others to learn from. All right, cool. I guess any last questions? Feel free to reach out on Instagram or email. But yeah, I guess we'll adjourn this meeting. Thank you, everybody, for joining. Thanks, Dr. Whitehouse, for hosting.
Thank you, everyone.
Thanks, you guys.
Thank you.